Welcome to today's educational session titled, How Virtual Care Will Continue to Transform Patient Care. Our speakers today are Anna Maria Tirano, working as the Chief Marketing Officer of Cinzi, and Jason Peoples, working as Director of Technology and Innovation at Mary Free Bed Rehabilitation Hospital. We would like to thank our sponsor for this educational session, GCX Corporation. Thank you to GCX Corporation for helping make this educational session possible.
Hello, Health Connect Partners attendees. For the past 50 years, GCX has dedicated itself specifically to the healthcare industry, developing a unique understanding of the interaction between medical devices, users, and healthcare environments. In collaboration with our partners and customers, we create solutions that are utilized in virtually all healthcare settings to provide secure positioning, mobility, and ergonomic access to medical devices and computer hardware. Overall, we are committed to developing the tools and solutions to enable caregivers to deliver improved patient care. Our internal catalog is expansive, with over 22,000 component part numbers, allowing us to configure modular solutions tailored to the ever-changing and progressive healthcare environment. Our GCX representatives can help guide you to the perfect solution, whether you are an OEM releasing a new medical device or a hospital redesigning your patient engagement platform. With 5 distribution and manufacturing locations across the world and sales in every country, we have the ability to meet your demands and position product where you need it. Go to www.gcx.com to browse our solutions or call 1-800-228-2555 to speak with a GCX representative today.
Hello, everyone. Welcome to today's presentation regarding how virtual care will continue to transform patient care going forward. A little note about the financial disclosures. Jason Peoples is the Director of Technology and Innovation at Mary Free Bed Rehabilitation Hospital. I'm Anna Maria Tirano, and I'm the Chief Marketing Officer at Cinzi. In case you haven't seen Jason's bio or heard him present before, he's a phenomenal thought leader on virtual health strategy. Currently, he's employed at Mary Free Bed Rehabilitation Hospital, and he has really spent the bulk of his career championing the integration of technologies, especially telehealth and virtual care, to move patient care, the delivery of care, and access of care into the future. And I'm the CMO at Cinzi. I was responsible for launching Cinzi as a brand when it spun off from Stratus Video, telehealth. My background is marketing consulting, and I've worked with many pharma companies, med device companies, as well as the exciting intersection of healthcare, technology, and even telecommunications. Let's get started. Looking at the agenda today, it looks like we have a lot to cover, but it's actually very exciting topics. And these are topics which have probably kept everyone up at night as they relate to the pandemic over the past, say, 12 to 18 months. We're also going to talk about what this means going forward and why telehealth and virtual care is here to stay. So looking at the role of virtual care and telehealth, the COVID-19 pandemic has obviously forced all of us, healthcare systems, hospitals, clinics, providers themselves, to rapidly implement telehealth services. And the delivery of patient care in the U.S. healthcare system is forever changed. Everyone had to go virtual in the middle of a crisis, not necessarily having the luxury or the opportunity or the time to really plan ahead. So we must still keep in mind the essential phases of digital transformation going forward and how to best deploy telehealth and virtual care effectively. Whether or not your healthcare enterprise is ready to continue using telehealth or even implement virtual care to begin with, the new reality is that virtual care has actually arrived and here to stay. Technology, digital transformation, it has really changed how we live, how we shop, how we commute, how we drive, how we entertain ourselves, how we work, especially over the past year or so, and finally, access to health care. What everyone can really agree on is that digital transformation really involves pretty important changes to the culture of our nation, of the world. And what it essentially does is it puts the consumer, and in the case of healthcare, it puts the patient at the center of everything. And that's why it's important to look at healthcare as saying that, oh, telehealth is not a nice to have anymore. It's truly a must have. And going forward, we will all know that it's fully ingrained in our healthcare system once we drop the prefix of tele from telehealth and start talking about virtual care as just healthcare. So you might not be aware that telehealth has actually been around for decades. In fact, the very idea of telehealth was originally foreshadowed in an April 1924 cover for a magazine called Radio News. And what it had was an illustration of a radio doctor who was connected to a patient via both sound and live picture. And what's interesting is that at that time, radio had just begun to reach into American homes, and the first experimental television transformation didn't actually occur until 3 years later, in 1927. So if you look at the key milestones on this slide, they're really about how telehealth was initially introduced and deployed to address challenges of rural healthcare. And that applies to a lot of people today listening to the presentation, because you may be serving a rural population and thinking, how does telehealth work in terms of serving a vast geographical area where patients may have to, be challenged with coming in for, regular checkups, and it takes them maybe 2 hours even to get to them. And that's where telehealth is definitely a bonus for them. And then moving forward, the evolution of telehealth continues, and there's definitely more of a urban component in terms of how it's been used. And you're probably mostly familiar with the University of Miami School of Medicine, as well as the Mass Gen telecommunication links that have happened.
So let's talk a little bit about the role of virtual care at Mary Free Bed. I have been in the telehealth space for a little over 12 years, and I've seen a lot of different use cases. I never really thought I would be in really leading the telehealth efforts, but when you look at with being patient-centric and you really want to walk that talk. When I had first joined, the healthcare teams, looking at ways that we could increase access, the rural use cases were really very prominent. You think about being very loyal to your community. Let's say you are 30 miles away from a tertiary care center. Do you necessarily need to travel for care? So we look at, as Ana Maria had just spotlighted the evolution of telehealth, a lot of federal funding was really driven by grants to be able to provide healthcare access to rural communities where you have underserved areas that don't have the specialists that are able to provide those services. So think about a town of 9,000 people. Is there a cardiologist at a critical access hospital / rural clinic? A lot of times, not necessarily. So developing a pathway for telehealth to be exactly that, to drive that clinical care, that expertise to those rural communities, and really looking at ways to minimize the distance as a barrier to access to care. That's really been very exciting to see with what that has been historically, and really with where the evolution has been right now, transitioning from a lot of the traditional video conferencing systems that were just put in the clinical application, watching the advent of the rise of the on-demand services. Embracing mobile technologies has really been a very successful endeavor for us at Mary Free Bed. So let's talk a little bit about with where we are at Mary Free Bed, the role of virtual care. So I've been at Mary Free Bed for about a little over 5 years. And it was really all focused on all things virtual care, telehealth. And when we talk about post-acute care, we think about physical medicine. So that's what we do, is rehabilitation. We're all physical human beings. This is what we do. So being able to, provide services in a way that doesn't provide that hands-on tactile feel was a bit challenging. So what we really wanted to do was we wanted to start small and build on those successes. And really the bottom line here is really we wanted to enhance access, timeliness, and convenience. And, looking at with what the consumer expectations are. So we want what we want, and we want it right now, or we want it yesterday. So people's behaviors have changed, and the expectations have come along with being exactly that. Well, why can't I just do this on my phone? Why can't I do this on my computer? Why do I have to go in? So as we look at virtual care being a pathway for care delivery, it doesn't replace in-person services. Certainly you can't do an injection over a video screen. But what you can do is you can have follow-up visits. So I really look at some of that hybrid model moving forward. So as we focus on what the key principles are of virtual care at Mary Free Bed, this was very patient-centered, and that to me is the North Star in what we do in healthcare. We're here to help people. So we put the person at the center of what we do. We really can't go wrong. So this was really in focusing on improving access. We want to improve communication pathways with our clinicians, our physicians, along with our patients, and creating different avenues that we would be able to really incorporate into the care plan. So we wanted to maintain the integrity of the therapeutic value. Again, you think about physical medicine, you can't touch and feel someone. So early on with our virtual care efforts, some of our clinicians, and I think about our therapists in general, also think about a physical therapist not being able to touch someone. It's vastly different than what they've been trained to do. So we really wanted to focus on maintaining that therapeutic value and what we can do in a virtual setting versus what we do in office visit, exam room, or even a therapy gym. So the safeguards and the security are always of utmost importance. We want to make sure that we're having HIPAA compliant, very secure connections, also rolling into the security of that, and really blending into what the regulatory guidelines are, being able to obtain consent and really the documentation that flows behind that. So, as we talk about what we have done at Mary Free Bed, it's really, virtual care is following the trend of all technology advancements. We're providing a service that people can access in the palm of their hands. And I think that, as we have evolved over time, most people have a smartphone. So it's really, there's certainly a fear of missing out if you don't have that smartphone. What notification did I miss? The average person pulls out their phone 150 times a day. I don't know if they're looking at time or if they're looking at date or the next notification that they missed, but they're almost on autopilot. But there's a fear of missing out if you don't have that device. So embracing that in healthcare, in the consumerism of healthcare, why wouldn't we be able to look at using that device that most people have with them for access to care? Kind of vastly different, but the expectations are there. So virtual care during COVID-19. So as I've been carrying water uphill for a number of years, what did this look like? So we had really built a lot of workflows into what we had established as far as our operations team. So again, really starting small and building from our successes there. So working with our operational leaders, being able to really take the compliance and the HIPAA concerns really into account. How do we integrate this into our environment? And what I really wanted to do is drill into what the workflows that we have already established today. So what I didn't want to do is create a workaround because it's easier to do that. No, we really wanted to integrate this into the way that we have established workflows already. So it didn't become the stigma of just one more thing to do. So identifying what the visit types were, the length of the visits, being able to have that easily scheduled by our scheduling team. Of course, there's insurance verification on some of these instances, but really incorporating that to what we already do, which became a natural evolution from the foundation that we built. So during COVID-19, that we were able to really flip the switch and build on these small use cases that we had and really go organization-wide. And we talk about organization-wide at Mary Free Bed. We are located in Grand Rapids, Michigan, and we are not the center of the universe. We are that complementary partner to a lot of acute care systems. So when you're looking for that higher level of care for patients that have gone through the acute care systems and really looking at Mary Free Bed, what can we do to increase this access to those patients at a time of crisis right now? So what we wanted to do is really scale this very, very quickly, and we had a lot of success being able to do that, again, just building on the foundational blocks that we had put in place because we'd already established that already. So really, as we're scaling our virtual efforts across all service lines at Mary Free Bed, so everything from inpatient to outpatient, and I would put a spotlight on our orthotics, prosthetics, and bionics teams as well, where we are caring for amputee patients. So you already have a limited mobility challenge with our patient population. So what we really wanted to do is recognize what the needs of the people are in this hypersensitive environment where we're all wondering, oh my gosh, what does tomorrow bring? It's not guaranteed necessarily. So what we really did is we scaled this very quickly. And I would say very quickly within 36 hours across the organization and our outreach locations. Really, again, putting the person first at what we do. And virtual was very successful very quickly. And what we found is that over 90% of the people that we are connecting with from Mary Free Bed were using their mobile device. They're using their smartphone. So again, it kind of underscores with what we have been talking about with with what some of those expectations were from the patient perspective. Why can't we do this? So, really from the patient perspective, we wanted to maintain the safety of the patients, of course, but also the safety of our team members that are providing in-person services. So while we went virtual overnight, essentially within 36 hours, we wanted to really identify what the guidelines are and really maintain that. And everything was evolving very, very quickly. So from the patient perspective, they're quarantined and they're social distancing. They're being informed of that. Well, what does that mean for ongoing treatment and healthcare? So, of course, there was apprehension for any in-person visits. Do I need to go to the ED for certain emergent or urgent events? What are scheduled procedures? What does that look like? We talked about virtual not being the only pathway for care because, of course, you have in-person visits. We talked about injections already, but really being able to say, okay, I'm kind of questioning some of these elective surgeries that I was thinking about doing now. I'm forced to think about that a little bit differently. So there was a lot of anxiety around this from the people perspective. And I think that's very normal. I think we're all humans. We all were wondering, oh my gosh, what does this mean for everyone? Everything's shut down. So what can we do to reduce that anxiety, but continue the treatment of the patients too? So, in the hospital setting, our length of stay is around 14 days, a little bit further sometimes, depending on what the case is that brought the patient to Mary Free Bed. But we had limited visiting hours. We had restrictions in place that limited family members and loved ones from coming into the hospital. So you think about that distance from an anxiety perspective with not having your core care group surrounding you and being that support system. And all of a sudden, the only way that you can do that is on a mobile device, on an iPad, that you can have a video visit and incorporate your family into your patient stay. Lots of things to consider here. What I get excited about is the technology is really the easiest part. Bridge a lot of these gaps just straight through the technology that we've established already. So to me, that's the easiest part. It's how do you operationalize that and then really set that expectation for the team members to continue to support this, because it's not a one-off. It becomes how we do business and it becomes operationalized. So, but it does take champions to recognize what the opportunities are and do this for the right reasons. Again, we took the approach of being very patient-centered all along to be able to think about, all right, what is the patient going through and how do we enhance their time at Mary Free Bed, their experience at Mary Free Bed is what this is all about, to have the best outcome that you can. So we look at this from a provider perspective as well. So, in the height of the pandemic, PPE is real. We had to have it. It was across the healthcare systems. We all heard about the shortages of that because, the scalability was not needed until we needed it. So we wanted to recognize that in our hospital setting, that we wanted to, really identify the right team members that would be visiting with the patients, treating the patients in our COVID environment. So we really wanted to minimize interactions and incorporate virtual care where we could. So while we are that quaternary partner, we also have specialty services that can connect remotely into our hospital setting to provide, again, access to those resources. Or if there is a neurology follow-up or consult that's been ordered from an acute care hospital to that patient at Mary Free Bed, we can facilitate that with voice and video as well. So we're not packaging up our patients and really essentially transferring them over to said office visit for neurology consult in this instance and bring them back to Mary Free Bed. Lots of exposure, lots of time, lots of inefficiencies there. Technology's there to bridge that gap all day long. So we really wanted to be very mindful of the resources, and we're talking about PPE in this instance with what we could do to really be smart with the way that we are managing the limited resources that we have, along with our team members, along with our patients all along the way. So from also, diving into the provider perspective, we had restrictions on seeing patients for in-person visits. I think we kind of covered that with a lot of our use cases, really talking about neurology as a driver, for that. We're also treating patients that have COVID-19, and, we wanted to be a community member. And while we are post-acute care, we also wanted to recognize that, surge is real, and how can we be a good partner to our acute care systems along with our community? So we opened up a COVID unit, and we wanted to be mindful of that and also expand to be able to maintain with the rehab patients that we have, but really, again, offer that community benefit. We didn't want to turn anybody away. So we went through a large surge planning along with Incident Command, lots of conversations with a lot of our partners, not only locally, but across the state and across state lines. What do we need to do to prepare for an influx of patients that will be coming through the acute care systems and then potentially over to Mary Free Bed? So there were a lot of discussions. Do we take COVID-19 patients that are outside of rehab? We were certainly poised to do that should the need arise. So again, thinking about the communities at large, what we do to help people in healthcare, that was something that we wanted to really take into account as we go down these journeys. So we also wanted to provide care in a safe manner, limiting the exposure. So you think about infectious disease, and that's really what COVID-19 is all about. Again, being able to have an infectious disease physician be able to connect remotely to the patients in our hospital or even a follow-up consult outside. We think about COVID-19 almost running like, it's run its course. What happens then? Well, these are debilitating conditions with some patients that have underlying conditions as well. So what does a recovery program look like for a patient after they've been through the hospital with COVID-19? What does that look like from a rehab perspective? So we're all about returning people to form and function and really transitioning them to that next normal. So we took that into account as well, and being able to recognize not only is this is real, this is an opportunity to help more people in a way that maybe we hadn't thought of before. So when I put on my innovations hat, we truly were innovating every step of the way. So we also really wanted to focus on maintaining the compliance, with the contact with the patients, with our communication strategies, with our nursing staff, with our physicians, with the patients, with the family and loved ones, with the care managers. What does that care transitions look like for that? So we wanted to take the guidelines that were put in place during the public health emergency, and with CMS and the government really rescinding a lot of the telehealth restrictions that were put up as, I hate to say artificial barriers, but that's kind of what they were, in determining who could provide telehealth services, where the person can be at time of service, what payers are reimbursing for this right now. So, the rapid adoption was real because of these restrictions that were lifted. So we didn't have to look at just metropolitan statistical areas as a barrier to provide access to services in a community where you have all of those pieces in place. It's not just rural community in the hub and spoke model, this is direct to person. So that was a huge boon for us to be able to really embrace that and take action pretty quickly. So when we were looking at, the pandemic at Mary Free Bed, this is just a snapshot of what we had really placed on our website. You can see March 12th, right as the public health emergency was being announced. Of course, this was updated in March 27th, 2020. This was really about, here's our stance with this. We want to protect our patients, our staff, and the community at large. So we always work diligently to help people all day long. We have enhanced protocols at this time, lots of uncertainty. So what we wanted to do is really underscore, what we can do effectively and really be a good community partner. But we need to be loud and proud about this because there's so much anxiety around COVID-19. It's very new. Nobody knew what was to come next. So what we could do is really underscore with, what we're doing and the why behind it. But we really wanted to provide a spotlight as we have continuous therapy treatments and different complex programs that are multidisciplinary. So we wanted to really focus on, hey, we're not going to stop treatment with you, but we're really going to convert this over to a virtual setting. So that's when virtual really catapulted, because it wasn't just about our physicians anymore. It was about our patients, our therapists, our clinicians. If we roll in PT, OT, and speech into that mix of historically consulting providers, clinicians that weren't able to provide telehealth services, not in a meaningful way, but in a billable and reimbursable sense. So we really wanted to recognize that. So it was an opportunity, but again, healthcare, we're here to help people. So the provider adoption before COVID-19, you're looking at about 18%. So that is for a multitude of reasons. Part of that was provider interest or opt-in, if you will. There's usually an organizational strategy and push to be able to say, okay, how do we want to help people in our community in different ways? Well, I'm a physician. I don't want to do that. Well, I guess you don't have to. So what is that opt-in, opt-out strategy? So as you can imagine, as we've gone through the public health emergency, the adoption since COVID-19 has really been 48% and rising every day, because what we're recognizing is that you can develop effective clinical pathways that would tie in with an in-person and a virtual model. really thinking about, do you need to come in for every single visit? Or what if we develop a strategy where I see you for your initial visit, and in the follow-up visits, I can do these virtually. You can stay at home and do this. So again, kind of blending with what the expectations are of people as they receive care in the post-COVID world. But it's really been an interesting ride to be on to see with where we were to where we are now. And of course, there's this yearning to go back to the way that things were. I'm not even sure what that looks like anymore. I really think it's that step forward strategy is, trying to embrace with what we do and incorporate that into just how we deliver care at Mary Free Bed. As Ana Maria mentioned before, if we can take the tele off health, then we've got just health. This is what we do. And using virtual care as a way that we just integrate that into our care delivery, we're not labeling things. This is just how we do business at Mary Free Bed. So the rapid expansion, as we talk about that at Mary Free Bed, I think we kind of talked about this a little bit before, but again, this is really all about access to people, access to care. So we really look at this as a pathway, again, to expand our services, but really drive that patient access piece. So we look at the cost efficiencies, the cost containment, cost reduction, leading to increased efficiencies with that. So again, does everybody need to come in for every single in-person visit? We'd also looked at strategies, especially during COVID-19, where people are aching to get out, but yet they couldn't because there was a sense of panic. So, we had some cancellations, we had some no-shows. So really being able to, again, integrate this into our workflow, into the dialogue for patients calling to cancel. But what if we were able to offer you a different pathway to access care, have that same visit that day? I don't even have to leave the house. So really it was a way that we would be able to say, okay, with the resources that we have open slots on our schedule. Instead of a cancellation, why don't we convert that to a virtual visit? And that was pretty effective as well. So again, we talked about patient demand. It reduces travel time, patient-related stress. It's, we know that during the height of the pandemic, there's a tremendous amount of anxiety. And that is just during not just during the pandemic, but that could be for any situation, any case, any condition that a person is going through. How do I access care? Oh my gosh, I don't know what I can do anymore. So we really wanted to incorporate strategies to lower that stress level. But again, embracing the mobile environment, the expectations that people have, consumerism of healthcare is real, whether we recognize that or not. As more health plans and employer groups are really pushing people to have HSAs and high deductible plans, you are a consumer of healthcare with that HSA card. You're swiping dollars for with healthcare services. So embracing that model and really recognizing that in healthcare, I think that's a differentiator, and I think that's one to not be taken lightly. But again, with what we have seen and really witnessed through the data that we've had in our experience with virtual at Mary Free Bed during the pandemic, we really want to serve people in settings and formats that they demand, and that's going to be your mobile device. So that's been very, very interesting trends. We kind of expected that, but really to see the data to validate that. The efficacy is there, so we don't want to ignore that, and I think that that's kind of the fear of the future is with people having more connected devices and wearables and sensors. Where does that data go, and how does that flow into the healthcare system? I think that adopting that model is going to be extremely important because, again, we as consumers, have these Internet of Things devices that we can incorporate into our lifestyle. They're really flowing that information into the healthcare system in a holistic way, so it provides a full picture of data that's being gathered that you can share with your provider, your PCP, whomever that is, in a medical home model is really, really important. So shifting back over to operationalizing within 36 hours at Mary Free Bed with virtual care during the pandemic, we know that the pandemic really pushed this into the future for us. A lot of our outpatient workforce is very therapy-driven, and as you can imagine, looking at what the CMS guidelines are, which a lot of commercial payers will follow, the distance site practitioner list is limited. So as we talked about our physical therapists, our occupational therapists, our speech therapists, they were never on that list to be able to provide a billable/reimbursable service via telehealth. So that was something that, with the barriers being taken down, we really pushed us into the future. And we were really looked at leaders amongst our peers in the post-acute industry of, hey, you guys were able to do this really fast. How did you do it? What would you do differently? And what can we learn from you? So it was really exciting to be, really in the driver's seat of that and to have collaborative conversations in the physical medicine space where virtual was really non-existent before, outside of more of those traditional physicians, nurse practitioners, mid-level providers that could provide the services in a billable and reimbursable way. So we really looked at the foundation of virtual at Mary Free Bed. You know, we talked about starting small and building on those successes and being able to build from the foundation that we had with the workflows that we had established that became the workflow. It didn't become a workaround that people had to really think about. It was something that was just ingrained, incorporated, and that was really the scalability that we had established that made this a successful rollout. I think that we probably could have shortened our operationalization when we flipped the switch from 36 to 24 hours. But as we added hundreds and hundreds of therapists to our platform, which we use Synzi for our virtual care platform for secure communications, voice and video and secure messaging, along with assessments with this, that we really needed to provide a pathway for our clinicians, but we had to build the profiles. Not only did we have to build the profiles, we had to educate elbow to elbow along the way. So it took us a little bit of time, just a little bit of time, but that was a huge building block that we could really step up from and operationalize that quickly. And the strong leadership buy-in across the organization. This was not an opt-in and opt-out. This is, hey, we're shutting our doors for non-emergent instances. So everything else is going to be virtual, and it was go time. So we had that top-down approach, and it wasn't, hey, do you want to do this? Do you think that this would be fun to introduce into your practice? No, it was a have to have. So it was something that worked very, very well because we had to. So that was really, really a key benefit to have that strong leadership that really set the stage and the expectations for the organization. So that was really, really helpful for us. And I don't think that changing in the future. I think it's recognizing with what some of those reimbursement conversations will be with CMS as well as commercial payers, is there's a little more latitude with the commercial payers in the contracts that you as an organization have with those payers. So incorporating virtual care language into those payer contracts, I would recommend that you take a look at that and really look at what that environment looks like for you and what the future is going to bring. So use cases for virtual care, let's talk about that a little bit. I think that the additional use cases, you know, we talked about at Mary Free Bed. You know, we really started, when I say we started small, we really focused on with what the transfer process would be to Mary Free Bed. So we received a referral from an acute care partner for a patient that would fit our rehab criteria to get them into our environment. And what we had seen is that with the referrals that come into our office, that a lot of times, you know, you look like a train wreck on paper. Let's just lay it on the line there. But there's a lot more to the story, especially by the time we receive the referral. We have a nurse liaison that would go to the bedside of the referring facility, meet with the patient, oftentimes meet with the care manager, sometimes with the physicians, providing some awareness and education about the referral that had come to Mary Free Bed. Hey, this is all about Mary Free Bed. This is what we can do. But we talked about, you know, before about that train wreck on paper. Being able to lay eyes on that patient is certainly a differentiator. So what we wanted to do is incorporate our physicians who had questions about that referral to transition that into a potential admission. So with oftentimes what is not on the referral is the discharge plan. So we want to set our people up for success. We want to make sure you've got a good care team transitioning, especially, you know, let's use stroke as an example. Your world is upside down very quickly. You have to adapt to that. So we want to make sure that you've got the right care team to set you up for success. And, you know, any questions that you have, and just taking 10 to 15 minutes out as a physician to connect with a patient directly with our nurse liaisons at the bedside was a huge differentiator for us. And what we had seen is that even in an environment where we're laying eyes on that patient from a physician perspective, that we gained a lot of insight that we didn't have on paper in that referral. So the phone call was nice, but a picture is worth 1,000 words, and a video is probably worth 1,000 pictures. So in that real-time instance, we had seen that we were able to increase access for more patients to get into acute rehab by just having that 5 to 10 minute, sometimes 15-minute interaction with the patient, shy of a consult, but more of an interview and interaction questions. So that often tipped the scales in a big way, that we were able to really facilitate more patients coming into our system and our network partners. So we also talked about the clinician to patient aspect. So With physical therapy, it was a little bit different. You can see, one of the images we have here, spotlighted with one of our lead therapists, Chris Badgema, with the therapy band in front of a laptop that he just uses. This is an exam room that we have on our main campus. And Chris is actually doing a therapy session with the patient at home. So, again, that direct-to-consumer, that direct-to-patient interaction is huge. And what we have seen is that it can be done. And his colleague right below, you see the exciting hands right there on the video screen. There's actually an iPad that's used as the second screen that's on its side right there for the voice and video component. And then you've got the laptop, there that's running the medical record. So, the two-screen environment was really helpful. But what, again, embracing mobile, not only with our patients' expectations, but embracing that into our clinical teams as well. Two screens is a luxury. A lot of people working from home, it's like a have to have now. It's not anything. You try to go back to one screen, yeah, you're not going to do that. So what can we do to really think about, all right, we have iPads today. How can we leverage this device in a meaningful way? So incorporating that into our mobile strategies as well was really helpful. So we're not, trying to bounce back from one screen to the other, medical record to voice and video. That was something that worked out very, very well. And it was almost organic as we were, in the throes of this, using as many resources as we could, and then recognizing where the gaps were, having to order more equipment. And then there's shortages all over the place because everybody's gone, virtual. In a way, work from home is real. And then shifting over to specialists and patients. So we have a lot of specialty services in our quaternary environment that we have at Mary Free Bed. So in this case, we have one of our clinical psychologists who is a lead in our pain program as well as some general psychology. So again, we wanted to offer that specialist to service to patients and just do it via your mobile device. So that has been very effective as well. And we'll touch into a couple considerations with mobile users a little bit later on the slide deck. But also shifting over to the multidisciplinary programs here. So we have some programs that we spotlight, our pain program, our spine program, and our Center for Limb Differences program. This is not just physician to patient. These are also other care team members as part of that maybe post-acute medical home model where you've got your physician and you also have your other clinicians that are part of that care team. So physical therapy, occupational therapy, speech, psychology are all part of the mix. In the case with Dr. Fornes, with the multidisciplinary team really leading the Center for Limb Differences, we also had an amputee component to that as well. So we incorporate the amputee liaisons as part of that care team and really being able to say, hey, what we can do virtually is just quick check-ins has been very, very helpful. So it's really been a team approach, and we have done some handoffs from doc to, or from MA to doc to therapist to psychologist in some of those instances. So the technology is there to really bridge that gap. So it's not just one-to-one anymore. In some of those other instances, with patients that would speak a non-English, let's say, that we can bring in an interpreter on demand, anytime, any place, anywhere, to help facilitate any of those language gaps that may occur. So multiple participants in a video call has been very, very successful. And we throw that in a clinical context, the multidisciplinary, that's been very, very successful for us as well.
There are additional use cases above and beyond what Mary Free Bed is currently doing, and some of these are probably applicable to your own organizations, whether you're in a major metro setting, a suburban location, a rural location, as well as if it's one hospital, you're part of a health system, there's many locations, there's many offices, as well as relevant downstream facilities such as SNFs, ALFs, etc. But you could see from the additional use cases that virtual care really has a role in many ways, that a patient is touched, is treated, in a way outside of surgery, to keep them receiving the best care at the right time, so that you're doing absolutely the right thing for the patient. And I'll just touch on a few of these things here, which is, what we're seeing is very important these days, especially the hospice and the palliative care settings. Unfortunately, during the pandemic, hospice and, the related social workers, the related clergy people, as well as family members, were unfortunately restricted from seeing their loved ones in a hospice setting, or perhaps even at home or in a hospital during hospice times. And that, as a nation, everyone is kind of delayed some of that grieving process in the mourning that happens as a result of it. But virtual care kind of enabled one to be with their loved ones during those times. And I think it still gives all of us goosebumps when we hear from the hospice practitioners telling us how effective it was to kind of close the gaps, bring a sense of closure to the loved ones, the families, and the friends who were able to connect with their patients and their family members in this way virtually. Kind of, the next best thing to being there. And especially as air travel was restricted and people weren't, traveling great distances either, given the social distancing requirements, this really bridged that gap in terms of the care, the compassion, and the concern that was needed during that time. It also helped from a hospice standpoint is the kind of going forward treatment. So going forward, hospice, it's that ongoing care that can be provided to the family members. And family members don't always have the time, if they're back at work, the kids are in school and whatnot. And it's harder and harder for them to kind of take that time to go to a facility, a clinic, a specialist for in-person care themselves from a mental and behavioral health perspective. And what virtual care does, it brings the care to them on their time when it's appropriate and in the setting where they're most comfortable. And as much as we say, the hospitals are designed for the future and designed to be as consumer-centric as possible, we know that the data is still showing that everyone wants to essentially age and heal at home, and virtual care kind of helps you bring that hospital to home idea. There's three phases of the PHE. And, when we look at the public health emergency, what's kind of important is recognizing where we were and where we are now, and going forward where we're hoping to move forward in a much more, positive manner for all. So the first phase is that stay-at-home outpatient care, which Jason described at length what happened from the Mary Free Bed perspective. The second was that initial COVID-19 hospital surge. So what happened with the COVID-19 patients coming in, as well as then what happens with all those services, all those procedures which were delayed, which were essentially put on pause until the beds were freed up again, the specialists were freed up again, that they can come back. And that's a different surge, right, that happens in a hospital or healthcare setting. And now, hopefully, we are moving into that post-pandemic recovery. And with this hopeful transition, it's key to recognize that there still needs to be a transformation of health systems and hospitals going on, because you're shifting from crisis mode, where essentially it's a stopgap, that you're using technology to just get through the current public health emergency. And now you're looking for, how do we make this something that's truly sustainable, something that can be used going forward, and that has the additional use cases and Mary Free Bed's use cases highlight is that it's not just for one way that care is delivered, but for has many ways that care is delivered going forward. So in order to do that, obviously there's going to be a change in terms of people, the processes, the workflows, potentially the technologies even that were used for, to begin with. There was some relaxation of HIPAA compliancy that was going on during the public health emergency, and the smart organizations knew that what they didn't want to do is introduce something that just gets them by for the time being, but instead they were looking for the future and making sure that they were protecting the patients, protecting their organizations, their bottom lines from HIPAA breaches, which, that data can cost them in terms of both the risks financially, as well as the risks to their reputation in the community as well. And we all see, right? We've seen it even just the other day. LinkedIn had a breach. So what everyone wants to do is essentially stay out of the headlines when it's related to a breach of any kind of security, patient information, consumer information, et cetera. What you want to do is, of course, be in the headlines when it's something that you're talking about how innovative you are and what a respectful and credible member you are of the community and what you're doing to help advance community health. So some of the benefits of virtual care is what I call the 4Fs. So it strengthens really that innovation in the health system. So going back to kind of what I just said is that, any health system, any hospital, any clinic, what you want to do is be in the headlines for the right reasons and being seen as that innovative leader. And timing is everything. Many healthcare facilities first introduced telehealth really around stroke, because timing is so important there. And once they realize how effective it is and how they can quickly bring in that external consult from someone wherever they are at the right time to make sure that the patient is treated in the right way, they stepped back and said, so where else does this apply? Where else is timing a huge factor? But more importantly, where else can we make sure that we are elevating the quality of our care? And that leads into the idea of, okay, how is it flexible? What is a virtual care, a telehealth system that is flexible enough that really can be used across different use cases, and that it's not just specific for, say, wound care, or it's not just specific for, stroke or for mental and behavioral health. But, obviously when a healthcare system looks at upgrading or changing from their EHR, they're looking for something that works across departments, across facilities, and that's the same thing that you should be considering from your virtual care platform too. The other thing is looking at what can be future-proofed, or what is future-proof, that it's definitely a platform that works with you today, but also has you scale, it also scales with you. So it makes sure that there's that collaborative standpoint, that it's not just a one-to-one back and forth bi-directional communication between a provider and a patient, or a provider and another provider, but that multiple providers, multiple people can be brought in. And as Jason pointed out, what we have at Cinzy is actually a platform where you could have multiple participants. So you can have, of course, the physician, the provider, as well as someone who's doing a virtual consult, the patient themselves, a family caregiver, an interpreter if the patient is a member of the limited English proficient population and prefers to communicate in a language other than English, as well as a pharmacist if the patient's about to be discharged. The home health or a SNF administrator can be part of that virtual call, so that everyone ensures that the transition of care and gaps and breakdowns in those transitions are minimized, and the handoffs really happen in a seamless manner. So some overall benefits, of which there are many. What I will point out is really that probably the big thing is here, the data. It's really, stepping back and saying, now you're going to have data on your patients as to how receptive they are to this. Their level of satisfaction is going to increase, not just with the care that they're receiving, but also with that VIP element that helps them improve their own outcomes. It helps them recognize their own role in self-care and what they should be doing, both in the hospital as well as after they're discharged, to help minimize their return to the ER or the hospital setting.
So pre-COVID results of Mary Free Bed, we talked about this a little bit before with some of the use cases that we have. So around 68%, so our acute care inpatient rehab referrals were admitted after we incorporated virtual care. So that was a huge differentiator too. Again, just being able to take the time to lay eyes on that patient to get them in the right place at the right time the first time. That's what we want to do. We want to create less inefficiencies in our system. And it's easy to fight ourselves, but again, being patient-centered, we really wanted to incorporate these strategies. So that was something that was really important into our admissions workflow. In that middle column there, we were looking at 15%. So we had more patients that were cared for each week, just because we minimized the distance as a barrier for that. So when we were able to convert that into more patient time instead of white space time, certainly more productive in those instances. So, shifting over 80%. Our patients remain engaged and on track with their home exercise programs, with their care plans, their interactions with Mary Free Bed. So we really wanted to create a frictionless way for people to continue to interact with our healthcare. Really the bottom line is driving better outcomes for that. So oftentimes with limited mobility, you have another caregiver, you have someone else who's taking time out of the day to travel with you, to take you to Mary Free Bed or to your healthcare instances. So we wanted to really embrace that in a way that was meaningful for us. But again, being very patient-centered, we saw that this was a huge opportunity that we could help more people, and then the outcomes were better. And if you look at that from a patient retention standpoint, and I'm going to focus on physical therapy for a second here, where oftentimes you have your evaluation, you're set up for treatment, which could be 8 to 10 sessions. How often does well enough become good enough? Well, after the third or fourth visit, I'm well enough. I'm fine. I'm well enough. I learned what I needed to know. And then you kind of drop off the radar for that. So really, we wanted to think about well enough is not good enough, and what can we do to continue to engage our people that we're serving in meaningful ways to have the best outcome that we can. Again, tying back into the whole continuum of care, we really want to recognize that there's opportunities for education and ongoing care and advisement to be able to say, hey, you don't need to go to the ED for this. You need to go to urgent care for this. Do you need to clog up your primary care pipeline? So there's other pathways, and just being open-minded about that, I think, is also an important piece of the puzzle as well. So COVID results at Mary Free Bed. So we're going to look at a little historical data here. And as soon as we pull data, it's always outdated. But if we looked at with where we started in fiscal year 2018, focusing on physicians and some of our access initiatives, really, again, going small, building on the successes. Voice and video strategies were incorporated into this. So we had about 131 interactions, all meaningful interactions, but, kind of that low number growing from something to get somewhere. And then we saw accelerated growth in the fiscal year 2019, really incorporating the virtual care strategies with admissions across the Mary Free Bed network and other outreach locations when we talk about some of those physician-led services in the underserved areas where we could, again, we want to hold a clinic, but maybe we want to hold a virtual clinic the first and third Mondays of every month, again, to provide that specialty access to those communities. So the outreach efforts were really important as part of our growth. And again, kind of taking the tele out of telehealth, it becomes health. And then fast forward to fiscal year 2020, we increased that to 949 touch points and interactions with patients. So, and then we get into the COVID-19 pandemic. So when we flipped the switch and went operational on March 16th, from March 16th to March 29th, 2020, in that short time frame, those 11 days, we had almost 1,100 virtual visits and interactions with patients. So we leapfrogged everything that we had done in 11 days from the past fiscal year even. I mean, it was fascinating to see the accelerated growth with this. So it was widely adopted by our clinicians, our physicians, with a little bit of question, well, how do I do this if I can't touch them? Well, let's talk about with what you can do. As you can imagine, my glass is always half full, not half empty. So you tell me what you can't do, that's great, but now you've given me a baseline to say, let's talk about with what we can do with this. So tips and tricks, there's a lot of these opportunities to talk about with tips and tricks, but we're going to fast forward over to the reimbursement model here. So, something that I've looked at over the many years that I've been doing the virtual care and telehealth is, all right, what's a reimbursable service and what's a billable service? So we really wanted to take into account what those reimbursement models are. CMS does a nice job of providing guidelines about who can provide telehealth services, who are the distance site practitioners, where is the originating site, where can a person be at time of service to really follow in the traditional model of the billing and the reimbursement. So we always look to CMS for guidelines for that. But we talked a little bit before about some of the autonomy in the states that they have in those state payer contracts, as well as the commercial payers that a health system may have relationships with and what those agreements are. So there's reimbursement by Medicare, Medicaid, commercial payers, and then in a fee-for-service model, and this is where I really was taking a keen interest in what the on-demand model looks like as I was really watching this rise in 2014 and 2015. What does the on-demand model look like for primary care? So for certain acute conditions, I don't need to come into the office for this. I can do this on my computer, on my smartphone. So could we assign a fee-for-service for a virtual visit, let's say? So is it, I think the magic number before was around $49 for an on-demand visit. And of course, some of the insurance payers are like, hey, this is awesome, and it actually saves us less money if you do this on a virtual visit versus going into the ED, going into urgent care, trying to get a visit with your PCP or mid-level. So there was some flexibility there to say, hey, we could assign some fee-for-service to this, and it's a convenience. And what we have found is that employers and payers are saying, yeah, this is a great thing to do, and we're going to waive the copay for this. So all of a sudden, your $49 visit could be down to $20 or no copay at all. So that was really interesting to watch that. So it does provide some flexibility in the gray area that I think that, being innovative and what can we do outside of the services that are traditional reimbursable? What does an on-demand model look like? What does bundled look like in a post-acute setting? So lots of opportunities there, and I think that we're just starting to scratch the surface because of the restrictions that have been rescinded during the public health emergency. That kind of all bets are off for this. Anybody can provide a telehealth service. Well, I shouldn't say anyone, but there are a lot of those artificial barriers. We talked about PT, OT, speech, kind of being some of those other key clinicians that have historically not been able to provide a telehealth service and to be recognized for reimbursement. So that's something that we want to keep our eyes on as well. So lots of opportunity there, and I think that, again, we've just scratched the surface with that. So operationalizing at Mary Free Bed, we talked about this a little bit before, starting small, building on the successes, putting this into the foundation of what we do as far as our operation. Person retention is important with our system as well. A more engaged person is going to have a better outcome. So, we really have the underlying value of driving through experience and then the quality and the operating efficiency. So we don't want to do this just to do this. I don't love the brand new shiny object. Throwing technology at a problem is not the solution. But if you recognize with where those gaps are and how the technology can enhance and create those efficiencies in the spirit of what we do in healthcare is to help people, we really, again, focus on those key principles. Patient value first. Scalable infrastructure from a technology standpoint is important. Where you start today is not where you will be tomorrow or in 6, 9, 12 months or 2 years or 5 years. What does that look like? Ana Maria did a spotlight on the security check too. We want to stay out of the headlines, of course, unless it's for a fantastic patient story that we can share from our rehabilitation systems and network partners. So security is important, and there's a sense of anxiety out there. Cyber attacks are real. We're hearing about it. We're reading about it. We're seeing infrastructures being shut down because of lax security metrics, and that's a problem. So we have really put a focus on security to enhance our security posture moving forward. So there are certain key pieces that we have in place for that, as most organizations do, is really what is the risk to the organization, having a technology risk assessment. What does this mean from a cybersecurity perspective? Having some of those checks in the boxes with the due diligence, with what does the business associates agreement look like? Who's liable for what? So not only from a technology standpoint, from a business perspective as well. And that's one of the pieces that really is the foundation of a good partnership and a relationship with any of the technology companies that you're working with. And again, we wanted to focus on engaging our workforce, and that has really impacted our culture here. Again, driving the message of glass half full versus glass half empty. We engaged our people. We wanted to make enhancements along the way with their workflows. How can we use technology to help along the way here? And that's impacted the culture quite a bit because those barriers, I can't do this, are over. And through attrition over time, we may see those come back, but the expectations have changed too. So it's really created more of an innovative environment, especially with our clinicians who historically have been physical medicine, tactile feel, touch, hands, manipulation, and saying, hey, can I do this virtually? I love that because you're asking me, can I do this? I'm saying, of course you can. Let's figure out the right way to do this in the most secure environment that we have, along with minimizing any risk that the patient may have at home. And then we want to adopt the services as a mindset. So the adopting the services, again, we talked about taking the tele out of telehealth, it becomes health. I'm very service-oriented, so I want to provide that best level of service that we possibly can. But the service industry is disrupted by all of this. So what can we do differently, and what can we do better? What can we learn from other industries and our peers to really embrace that mindset and help people along the way? And what we know for a fact is that disruptive technologies will positively drive the digital transformation in healthcare. So we're seeing big tech companies come in. They're doing lots of things in the consumer space. healthcare has been often, well, wait a second, we can't control this now. Well, instead of ignoring that and kind of pushing that away, open up the floodgates and see, how do we embrace this? How do we roll this information into our environment? What does it look like from a health and wellness, a lifestyle perspective? So behaviors change when you make, again, kind of that frictionless engagement with your healthcare systems, because this is not going to stop. It's just going to evolve. And if you're not on board, you're going to be left behind, and people will be frustrated because they can't get into what they want. Patient portals are certainly one pathway. It's another username. It's another password. In the consumerism of healthcare, what can we do to enhance that? So, you kind of take your eye on the prize with what we could do differently, meeting and blending consumer people expectations into the healthcare experience. This is happening all day. It's how you roll that into your strategies that's going to really be a game changer. So lessons learned at Mary Free Bed, again, physical medicine, you can imagine, fish out of water. Oh my gosh, I can't touch and feel. What can I do? So we really, needed to work with and provide the assurance. You take the physical medicine, the physical out of physical medicine, it required a huge mindset shift. So again, with our physical therapists, occupational therapy, not so much, but even our physiatrists that are trained to touch and feel, and we're seeing this with our residents as well. So incorporating the virtual component into the way that the residents would, really roll this into how they practice medicine. It's no different than what others have learned in legacy, but some of those existing clinicians that have not embraced telehealth because it hasn't been that top-down approach. Do you want to do this? Well, no, I don't. Okay, that's a conversation stopper. But my competitive spirit's like, let's work a little harder on this. Let's figure out what we can do to help you incorporate this into our outreach and our growth as well, being patient-centered. So we also need to integrate our virtual care into the existing workflows. I think we've really set that as an expectation. Again, you can create a one more thing as a workaround, but really taking the time to look at what the processes are in place today, which often becomes an opportunity for process improvement. So then you reduce the stigma of one more thing because it becomes how we have operationalized it. Again, we've talked about smarting small, building on the successes. It drives awareness. There's some excitement. I can share with you that, especially as we started, with that narrow focus in the beginning with our inpatient admissions, there was a cluster of people outside of the rooms in the acute care facilities when we facilitated a virtual visit. Like, what are they doing in there? That's really cool. Why can't we do that here? So it creates, again, that awareness that Mary Free Bed is doing things a little bit differently, all in the spirit of what's best for the people that we have. So identifying and partnering with our clinical champions along the way has been extremely successful for us. So those are some things that we really wanted to continue to build on and keep it right in the front of our mind. And expect the unexpected. So anytime, any place means exactly that. So we've had some outpatient visits that, really in a non-traditional environment, I think that's been one of the scares of healthcare. Oh my gosh, well, what if this, what if that? In the pandemic, all bets were off with that. So we've got a series of graphics here that I think are pretty cool to talk about. So I'm doing a virtual visit at home, and Amazon's knocking on the door to tell me that they've delivered a box. Okay, that's a disruption during that voice and video interaction. It's also real. So again, connecting with any person, anytime, any place, anywhere is like the wild, wild west. You don't know what you're going to get, where you get it. In our experiences as well, some of these anecdotal stories, anytime, any place, anywhere. We've had some of our patients that have been in their cars. Some have been parked in their garage because it's their safe place. Some people have been driving, which presents an ethical dilemma when you recognize if this person is driving their car during a virtual visit, that's distracted driving. And we have an obligation to provide the most secure and safe environment. So again, it's happened, and we kind of curved that conversation. We've had some patients that have just simply pulled over or pulled into a parking lot once we kind of set that expectation with the patient, said, hey, we're here to help you, but we're not going to be part of a distracted driving incident. So that is a real world challenge. It's one you wouldn't think about, but it certainly is real. And then we've got patient in the bed or in another safe place. So I'm comfortable, I'm feeling bad. I mean, we don't go to healthcare to say, hey, tell me how great I'm doing today. It's usually because you've got an issue that you need some recommendations or advice or ongoing treatment for. So being in the bed is certainly a real world use case that we've seen too. And then I think probably the funniest graphic here is we have a someone in a bathtub. So one of our psychologists had a breakthrough moment with the patients and really talking about the value of psychology and engaging that person for continued treatment. And it wasn't until our consulting provider, our psychologist in this case, heard water moving around. So she kind of paused for a second, was like, is that water? And it turned out that the patient was in the bathtub with water because that was her serene environment. And it was interesting because our provider was like, yeah, should I continue to, this session because you're in a bathtub? Do I stop because there are some risks involved with this? So it was a conversation that needed to be had, but again, anytime, any place, anywhere means just that, even in a voice and video setting. So again, recognizing that is interesting. Some of these expect the unexpected. There's a ton of other ones that I could share, but really focusing on these four. It's been a fascinating experience, and I think again the mobile environment has enabled us to have the flexibility to do this. But again, I think having the dialogue with the patients, the people that we're serving, to kind of outline with what those are to minimize any risk is important too. But yeah, the bathtub scenario is one I keep coming back to because I just think it's fascinating. We've had some patients that have been in a closet, like I said, they've been in their garage, that serene place to be able to open up and to have an engaging interaction. So again, it's driving better outcomes. So, but again, we want to recognize that there is some risk involved with that as well. And then the measuring for success, we really wanted to put some ideas in place with how do you measure a virtual visit? Really thinking about, all right, you don't want to ask somebody, hey, were you happy with your visit today? Nobody's ever happy with anything. So we really wanted to drill into what some of those key measurements are to really determine what our success is. So what was the time to consult fulfillment? So being able to increase the access is really one of the core pieces that this is all about. So if I am a visiting specialist in a rural community or an outreach clinic, I may have limited availability just based on my schedule. Maybe I'm only there 2 days a month. Maybe I'm there 1 day a month. So again, thinking about, all right, if I'm there 2 days a month, how far out are you booked? Okay, so that could be a month, it could be 2 weeks, it could be 3 weeks, it could be 3 months even. So incorporating a virtual visit into part of that workflow, so saying, all right, if I'm holding an outreach clinic, for example, who do I need to see for those initial visits and face-to-face? And could I increase access by offering other follow-up visits in that environment virtually? So that could be in that setting, at the clinic, at the hospital, and a critical access, wherever the person may be, or is it straight to the person at home? So again, thinking about different ways to increase those access points. The diagnostic accuracy, more touch points means more engagement, which drives better outcomes. Again, driving the patient adherence, that really kind of underscores with what we've talked about here is the patient's retention, the engagement is really important. We don't want well enough to become good enough. We really want the best for our patients. So that was something that was really important to us. And when we talk about the readmissions, we have a couple initiatives underway, especially in partnership with our acute care systems of being good stewards in the quaternary area. So we want to set people up for success. We want to reduce readmissions, especially unnecessary readmissions, and identify the right candidates that could come to Mary Free Bed. And we know that our acute care partners, there is this real thing of the 30-day readmission is something that they get dinged for. So what can we do to be good partners with our acute care systems, but also, focusing on another area of opportunity that we've really just started to get our feet underneath us with is a care transitions program that we have to partner with the acute care systems and kind of be that medical home for some of the medically complex patients. So we're really having those touch points, those interactions with patients post-discharge from Mary Free Bed. And again, wanting to curb some of those unnecessary ED visits or even driving to a readmission, we really wanted to recognize that as an opportunity. And maybe that leads to an at-risk agreement with some of the acute care systems or other partners that you have. But that's just another strategy that, really incorporates what we do well in post-acute care as we look at the full continuum and then the partnership with our referral sources, our acute care systems, physician offices, whomever they may be. So also we wanted to look at our staff utilization and our satisfaction rates. So who is using our platform today, and what is the frequency, and how happy are you with that? So one thing that's been fantastic with the relationship that we've had with Cinzy as we've grown over the years is the real world feedback that we get from our frontline staff who are using the platform, using systems, being able to take that feedback back to our Cinzy counterparts and really reflect the real world feedback into digital road mapping for platform enhancements and changes. That's been hugely advantageous for us. So as we've had to pivot in healthcare, the technology being the backbone for that also had to pivot and listen to have, really that partnership so that we're using the right platform for the right reasons. So, driving patient satisfaction rates as well. A lot of organizations use Press Ganey as that benchmark. I think that's one piece of the puzzle, but I think really driving into certain satisfaction metrics based on accuracy of your diagnosis, being able to connect with the person, the ease of access, really focusing on certain questions that were related to that virtual visit versus your overall care. So that was a way that we can kind of differentiate between, hey, were you happy with your care, or what did this virtual setting look like? Would you use it again? Some of those things like that. And then the Mary Free Bed brand equity. What does that look like right now? And then being able to transcend from the artificial barriers that were put up because we built these telehealth pathways certainly increases our brand awareness and then some recognition, as we are not the center of the universe in Grand Rapids, but we do have a footprint throughout the state of Michigan, as well as northern Indiana right now. And we really have our eyes set on with what we can do to be healthcare without limits, without bounds. What can we do? We have some international opportunities that are coming down the pipeline as well. So we really wanted to be poised as the leaders in this space and be recognized that we are good resources and advisors and are happy to partner, share, have great conversations with other organizations, other team members, other technology companies as well. So we really wanted to expand our brand equity in that sense.
So virtual care can help your organization address the quadruple aim of healthcare. So when you look at improving the health of patient populations, what virtual care does is it brings your patient population the right resources at the right time to make sure that they're getting the right treatment as soon as possible. And the dashboard reporting helps you look at the trends of what's happening overall with your patients as well as specific patient segments and how virtual care has essentially helped move things in the right way in terms of patients being discharged faster, reducing the rate of readmissions, and them being much more satisfied with the care they received as well as the outcomes in their overall quality of life. The second of the quadruple aim is about how do you improve the individual patient experience. And what virtual care does is it really puts your patient, which is, again, back to the consumerization of healthcare, it puts the patient really at the place where they are in control of their access to care and really having that dialogue with you that goes above and beyond what just happens in the traditional four walls of a clinic, a practice, or a healthcare system and a health facility. So it improves their patient experience because it really makes them feel like a VIP, that they're interacting, they're engaging, they're receiving more communications from you, from your providers, from your colleagues in terms of what they can do that will keep them on track with their recovery as well once they're discharged. Now, of course, there's the idea of lower costs. And, part of the virtual care idea is that, of course, it really reduces that need for your specialists who are typically off-site or in remote or other locations, that they have to give up time, they have to incur transportation expenses and related liabilities to actually come to a facility to give a consult at hand. So it helps in that regard. But then broadly speaking, it also helps when you think about the aging baby boomers and that there's going to be such a, strain on the Medicare and even the Medicaid systems at place. This really helps these patients get the care, kind of keep them proactive, not just responsive to the care that they need going forward. And then the fourth aim of healthcare. It goes back to what Jason said about your clinicians and engaging your clinicians. It now gives your clinicians greater flexibility, greater satisfaction in terms of how they can truly touch the patients virtually, and being given that flexibility to give them care outside of the traditional walls, as well as outside of traditional times of healthcare too. And many health systems, many hospitals are seeing that the teletriage aspect is very important to them, because it's helping patients and their family members recognize that they don't necessarily need to go to the ER for every emergency, and it reduces that strain on an emergency room after hours as well as on the weekend. And that was so apparent during COVID times as well. So that's how, this really kind of catapults organization to then being in a headline for the right way of being recognized as a great place to work. So what's next? When you think about it, telehealth virtual care is definitely here to stay. It's not just something that was a quote unquote Band-Aid approach that happened during the pandemic, but it's now what not only your patients, but also your clinicians will expect to going forward. And what's next is that virtual care will help bring higher level care to the home. It'll help with the advance of the hospital at home and the SNF at home care models. It will also help addressing the staffing challenges that you face, as well as the partner organizations that you work with, by being able to bring in supplemental people and not losing time because someone is not physically in an actual office or at a facility or even on the campus. And then last, it'll prove the power of the data. So, value-based care is the future. Reimbursement, the emergence of fee-for-value and capitated models based on patient data and outcomes is what everyone knows the healthcare system in the U.S. is moving towards. And with virtual care, you've got not just that virtual visit component, but you also have the remote patient monitoring. You have the virtual and remote assessments that helps you truly monitor and manage patients once they're outside of your practice or outside of your clinic or your healthcare facility, and keep on top of their care. So it's important that, one thinks that, telehealth virtual care is not just the visit that goes on, but it's really this kind of ongoing relationship, this ongoing connection that you have with your patients going forward to make sure that they remain satisfied with their care, as well as that their outcomes continue to improve and it enhances their overall quality of life. So a couple things before I turn this over to Jason to kind of wrap things up going forward is that, you need to reimagine what care delivery looks like. And there's a couple questions that administrators and IT specialists and, even the clinicians themselves are asking themselves these days. One is, what do patients and their family caregivers now demand? Essentially, as we're in the post-pandemic hopeful phase, how has consumer use of technology changed during the pandemic? And then what's that impact for how they expect to continue to access healthcare going forward? Number two, what are new and emerging technologies that will enhance patient experience as well as patient engagement, both within your facility, at your clinics, at other care settings, as well as when the patient is back at home? What's the new world order for what happens in primary, acute, and post-acute care? And how can you reposition your facility, your organization, your health system so that you truly are, the best of the best? You're the source for your community, as well as you're the trusted source for the referral partners that you work with as well. And then last, what's the appropriate balance between in-person and virtual care going forward? And with that, I'll turn it over to Jason.
Yeah, thanks, Ana Maria. I think that, really timing is everything with telehealth, and time is of the essence with in-person care. We talked about some of the telestroke models that really was one of the really big use cases for telehealth, being able to have a stroke neurologist connect to an ED doc, a hospitalist, and administer recommendations to administer TPA. So we have some life and death situations that virtual care is certainly a good access avenue, but it's, again, people want what they want, and they want it right now. So whether that's emergent to them or maybe not so much, but really we wanted to think about why telehealth and virtual care is the pathway to really go into that expectation with the people, and then with our clinicians embracing that as well. So time is of the essence, telehealth now. And then, really looking forward to Ana Maria's point, what does that look like in the future here? So, we talked a lot about virtual visits. We touched on remote patient monitoring a little bit, as well as the consumerism, the Internet of Things being rolled into what that holistic healthcare experience looks like. But, really as we look forward, we want to focus on what the user experience is. Frictionless environment to have access to care, to have your providers, your healthcare system, driving improvements in satisfaction across the board, whether that's clinical satisfaction or whether that's the person, the patient. So, again, the person is at the center of what we do to really position that in a way to walk that talk, really have that VIP treatment of our patients, our caregivers, to say, we are in the moment with you here right now. Some of the conversations and the research is showing that we've had, and as we've had thousands and thousands of virtual visits over in the last year, is that there's a perception from the patient that their care team, their provider, their clinician is feeling that they spend more time with them in a virtual setting than they do in an in-person setting. So I found that kind of fascinating to think about that. Again, we want to expand with what the models are for our use cases for inpatient stays, whether that's a quick visit with a family member or loved one, that also rolls into virtual care. Secure messaging, being able to snap a picture with an image for wound care to get that to the right clinician, to the right physician, is extremely important too, as we talk about some of the other opportunities of care transitions and rolling into discharge and touch points with the patients and assessments, the messaging, we touched on that already. That's all important as we expand from where we have been. And then again, we recognize that there is more than just voice and video to our virtual care strategies. So again, blending that into the consumer expectations, the people, the devices that you're using already, rolling that into how we aggregate that information into a holistic way. That's really with what we are challenged with as healthcare, because it's outside of our control. But the data is real, and we need that to be able to provide the best recommendations and treatment plans for the people that we serve. So we also want to really include other additional team members as part of those touch points with the patients. Our care navigators, our care managers, our social workers, our dietitians, infectious disease, any of our outlying providers that could be part of that care team, again, and that easy access that we would want to provide. Telehealth is a compelling way to do that. And then we really wanted to ensure the reliability, the usability of the security of the platforms that we choose to do. So again, we want to stay out of the headlines, but we want to maintain the compliance, mitigate the risk as much as we can, but provide the right services for the right reasons and in the most safest and secure way possible, really enhancing our security posture. And again, I'll say this probably for the third or fourth time, if we take the tele out of telehealth, then it's just health. It's how we roll in healthcare at Mary Free Bed. This is what you can expect. This is what we do. And driving to digital health, I think we touched on this quite a bit throughout our session, with this, but really, we have our Apple Watches, we have our Fitbits, we have a lot of data that's out there. There's over 150,000 health apps that are on the Apple App Store right now. Some of those are physician recommended, some of those are clinician recommended, some of those are simple wellness, mindfulness, exercises, activities that you can incorporate into your lifestyle. The wearables, the sensors are going to get better and better and better and more accurate. And that's going to be huge. So outside of that, with the remote patient monitoring, some of those traditional medical devices that would be under the durable medical equipment arena, or I would even look at that as a prosthetic limb with a bionic chip in it. That's technically a medical device. So how do we embrace that as far as healthcare? Provide more self-sufficiency, and then again, we're thinking about the care transitions. We're thinking about patients going back to the ED or to the acute care system for an unnecessary visit, or even leading to maybe what could have been prevented as an admission if we're able to outfit remote patient monitoring, smart scales, blood pressure cuff, pulse ox, things like that. That would be really sending the data from the patient up to the secure cloud. We as clinicians access that data and say, hey, Mrs. Smith, you're a diabetic patient. We noticed you didn't step on your smart scale for the last 5 days. Let's talk about that. Let's have a conversation to get you back on track, because we have your wellness at the first and foremost in what we do. And then the technology, we focused a lot on our voice and video interactions, and I think that's kind of one of Cinzy's sweet spots right now, is really the voice and the video pieces. So we really wanted to incorporate this into a very user-friendly platform, not only from our patients, but from our clinicians and providers that are providing those services. So again, leveraging the devices that we have. The days of having a telehealth room or even a cart, they're by the wayside. Certain use cases certainly are applicable to that, but again, what are the tools that we have around us? How can we leverage the technologies around with what we do? So at Mary Free Bed, this is really virtually everywhere. We can connect with any person, anywhere, on any internet-enabled device. And this is personalized, going back to Anna Maria's point about that VIP. This is your rehabilitation. This is your care team. This is what we do, and we really want to focus on what's best for that person. And the look forward, the hybrid model is real. So in person, virtual. So I think that there's a lot that can be gained from the evolution, recognizing with where we are today, then the evolution of where these technologies are going in the future with secure messaging and being able to have the assessments and certain points and surveys that we would want to really aggregate that data with and take a nice reflection on, and how we would be able to incorporate that into more of a learning health system model. So closing thoughts, we'll just close with a quote from our Chief Medical Officer, Dr. Jakubowski. And when we talk about telehealth, I was carrying water uphill for quite a while, so it was nice that we had some engagement from our leadership team. So coming from our Chief Medical Officer, really, telehealth is another means that we can reach out and extend the expertise that is in the quaternary rehabilitation facility and extend that reach to the rest of the state and beyond that. So I think that's a testament to our leadership team and really setting some of the foundational ideas with what we can do differently. And we are going to look different, because the future, we don't know what it will bring, but we can be poised in the best position we can be to embrace with what we do know and incorporate that into our digital roadmap and our strategies as we look forward. And at Mary Free Bed, really the big picture is the patients walk out on us. So we spend the time to work, engage, interact, have the touch points with our patients, and we're really focused on taking this person who's been through an event that has brought them to Mary Free Bed, as simple as that may be. Maybe it's an ankle sprain from a sports injury. We really want to engage you, set goals, and we really want to set you on that path to that next normal. So this is just a snapshot of one of our outdoor advertising campaigns that we had, and really our patients walk out on us, and that's what we do. So we really focus on those outcomes. So with that, we certainly appreciate the engagement and the time, and feel free to field any questions our way, and we will be happy to facilitate any answers and circle back. We're also happy to be any advisors in this space as well. So any questions, any thoughts, any comments, any other use cases, we're always happy to field those questions as well and have good dialogue.
Thank you to our speakers Anna Maria Turano and Jason Peoples. And to our sponsor, GCX Corporation. Thank you for attending our 2021 Fall Online Hospital and Healthcare IT Conference. Have a great day.